All right. Hi, everyone. My name's Lizzie. I'm one of the people on Muppets doing the revision lectures. So, my talk is on infectious diseases, genetic conditions, and dermatology conditions. So, this is my email. If any of you have any questions after this talk, feel free to send me an email and I'll try my best to answer them. So, just a disclaimer, I've adapted a lot of this information from the 2024 lecture, but for new matrix conditions or to supplement some of the information, I've used my own notes, the really thorough Muppet summary documents that the academic team has made, and then also, of course, the RCH guidelines, which are the gold standard. And I'd recommend for your revision, definitely having a look at all the most up-to-date RCH guidelines because they're, as I said, the gold standard. So I've also tried to label all the conditions with whether they're R1, R2, R3 as best I can. Some of it is a bit unclear, like for childhood viral illnesses, I've covered a range here, but they're all technically under the one condition that's just childhood viral illness as an R2. So first I'll be going through viral rashes. So these are the range of viruses. The first one is measles. So to categorize the rash, it's a blanching erythematous maculopapular rash, which usually starts behind the ears and then goes down the trunk. So they're confluent spots, meaning that it merges together and usually lasts only up to a week and eventually peels in that second week. So it's important to note what the prodrome is for measles. So it usually consists of fever, conjunctivitis, coryza, cough, and also Koplik spots, which you can see in the image on the left. So they're those small white spots sort of on the buccal mucosa opposite where the molars are. Management for measles is really just symptomatic. So you can give obviously pain relief, vitamin A for younger patients if their measles is really severe or if they're immunocompromised. But for most viruses, which you'll see, you have to remain isolated from school for at least 5 days. And then also the Department of Health needs to be notified within 5 days. For measles, something that's really important is to note what the complications are because it can lead to more serious things. So that includes otitis media, pneumonia, encephalitis. And the really red flag one that you should remember is subacute sclerosing panencephalitis. So that can lead to death within, I guess, 1 to 3 years from diagnosis because of demyelination in the brain. So it can lead to a range of neurological conditions and it's really quite debilitating. So the next rash I'll talk about is rubella, which is very similar to what measles looks like. But the way to differentiate it is to remember that rubella is non-confluent, very itchy, and doesn't peel at all. And it's usually a lot quicker than measles, or it should just disappear by day 3. Symptom management is, again, pretty much the same as measles, and you have to isolate for at least 5 days from school, and then also notify the Department of Health within 5 days. So chickenpox. It's important to note the prodrome, the rash here. So eventually it starts as vesicles that then rupture and then crust over. So all of them should be fully crusted over by 10 days. And that's when kids can return to school. So they need to stay isolated, not just for the 5 days, but until everything is crusted over. And all the management, again, is symptomatic. You can give calamine lotion if there's any itching, but you can also think about giving aciclovir, especially if the patient's a neonate or they're immunocompromised. This next one is Erythema infectiosum. So that's parvovirus B19. And you can see there that slap cheek rash, which is the sort of red parts of the cheeks, and they become more obvious after being out in the sun. But the kids don't need to isolate from school. That's usually because they're infectious until that rash appears, so you might not know that they have it. This next one is Roseola infantum. So that's HHV6. And the rash actually comes after the fever. So the way to remember it is that it spares the face. You might think it's very similar to a rubella or a measles looking rash, but this one is itchy and painless and it spares the face, as I said. This next one is hand, foot, and mouth disease. So that's Coxsackie-A virus. In writing on an exam, you might hear it described as a red-pink macular rash with grey elongated vesicles. And obviously, it will specify on the hands, feet, and mouth. So it's spread when the blisters actually burst. This next one is Molluscum infectiosum, which isn't that serious. It usually regresses within a year and patients don't get any systemic symptoms, but it's really highly contagious in kids and also sexually active young adults. So you can notice what it looks like, or you can differentiate it by that central umbilication. So it has sort of a dent in the center, and they're described as round pustules. This next one is herpes stomatitis. So that's HSV, and it causes this vesicular rash around sort of the mouth. And because it's very painful, kids are at high risk of dehydration if they don't want to drink, and it can also bleed very easily. This next one is Pityriasis rosea. So I think this is very heavily covered in GP from memory, but it's important to know especially what the rash looks like. So it's usually sort of a viral urti at the start, and then the rash will come first with a herald patch, so quite a large, like salmon pink, scaly patch somewhere on the trunk, which eventually turns into this Christmas tree distribution, which you can see in the image there. But it's usually common in older people or older kids, young adults. It resolves usually after 2 months, and sunlight actually helps with this condition, but you can't really help it along at all apart from symptom management. So with antihistamines or topical corticosteroids if it's really itchy. So that brings us to non-viral derm issues. So this first one is Staph aureus, so Impetigo. So it's this honey crust appearance, you'll hear it referred to as, and it's usually around areas of broken skin where Staph aureus can infiltrate. So that can be like around the perineum or buttocks for younger kids, or around the face, especially the mouth. And it's really contagious by touch, so it's spread in schools. The management is really to minimize the spread of infection. So to avoid contact, stay home from school, and then also cover the sores and wounds with dressings. For smaller lesions, you should put a topical antiseptic or mupirocin. And then for more systemic treatment, it's Fluclox or Keflex. And it's important to watch out for any complications, because obviously Staph aureus can become a systemic infection. This next one is scarlet fever, so caused by group A strep. And it's described as a blanching sunburn appearance with a sandpaper texture rash, which you can see in that bottom photo, and also a strawberry tongue. So the rash actually spares the area around the mouth, so that's referred to as perioral pallor. And usually the fever starts, and then half a day to 2 days later, the rash will come. So the management is phenoxymethyl penicillin orally for 10 days, and kids need to stay home from school until at least 24 hours of that antibiotic treatment is reached. And you should definitely remember the complications of group A strep, especially in certain demographics of kids, because it can lead to things like acute rheumatic fever, acute post-strep glomerulonephritis, which is covered by other lectures. It's in other parts of the matrix, so I won't go into it, but make sure you do know all the things that group A strep can cause. This next one is scabies. So scabies is caused by a female mite burrowing under the skin and laying eggs. So once those eggs hatch, it causes, the mite releases antigens, and there's a hypersensitivity reaction, which leads to this rash you can see in these images. So it's usually sort of in the palms, soles, webbed areas of the body, and you can diagnose it by microscopy of the skin. You should definitely watch out for any superimposed bacterial infections, especially by taking a social history and just understanding sort of what conditions, or depending on what parts of the body the scabies rash is, what could get infected. So the management is washing clothes and hanging them to dry in the sun specifically, and then treating the whole household, even if they're asymptomatic. So the treatment for that is permethrin 5% cream overnight in the affected areas, and then it should be washed off in the morning. So atopic eczema. This is an R1 condition, so very common. It's really intense itching and dry skin, so it can affect different areas depending on the age group. For infants, it's usually the face, head, extensor surfaces. And then once children are older, it's the flexural surfaces. So I think everyone knows this by now, but remember it's associated with the atopic triad. So eczema, hay fever, and asthma. And the management is a really important thing to remember. I think it's tested quite a lot. And you might get an apex station maybe on counseling families. So remember to talk about the triggers. That's one stage of the management, is avoiding things that trigger people's asthma. So that can be perfumes, detergents, fragrance. But pharmacological management, I guess the first one is emollients. So just making sure you're moisturizing the area. Second line is any topical steroids, making sure just to put it on the patch of eczema and not any of the surrounding skin. Third line is wet wraps. So that's applying a topical steroid and then wrapping it in, I think people use Glad wrap, bandages, anything that keeps it on there to just increase. I think someone told me it's the absorbance, but if you just remember increased potency of the steroids, that's what's important. Third line is also phototherapy. And then fourth line, I think it's quite rare, but there is systemic steroid use. That's a last line option. Next is seborrhoeic dermatitis. So its buzzword, I guess, is erythematous plaques with yellow crusting, and it can lead to a butterfly rash. So it's just commonly in areas with an increased number of sebaceous glands, and it can lead to cradle cap in babies. So that's that itchy dandruff you can see there in the image. Management is to avoid sunlight for this one and to gently apply lotion or moisturizer to loosen the crusts. And then you can sort of scrape at it very softly with a soft brush, like a toothbrush, and then also using anti-dandruff shampoo. So that usually resolves it. But if there's broken skin, you should be aware of any secondary bacterial infection. Next is cellulitis. So I think the important ones to remember for pediatrics is periorbital cellulitis and orbital cellulitis, which is covered in a different lecture, a different part of the matrix. But I'll give you the general information about pediatric cellulitis. So the most common causes are the classic things that affect, so it's group A strep and Staph aureus, but you should remember or have an idea of the mechanism of infection. So if it was an animal bite, a human bite, a foreign body, or if you think there's deep structure involvement, or if they're sort of someone that's been in the hospital for a long time and you're concerned about MRSA, for example, those are some of the red flags that you might consider during deciding what treatment to give. So investigations, you can swab and culture if there's any discharge. Usually you shouldn't do a blood culture unless it's for severe cellulitis, and you can consider some imaging if you think there's an abscess, or again, the mechanism of infection might be a foreign body being left in there, if there's any deep infection, deep structures. But here I've taken this straight from the RCH guidelines for the treatment. So I would recommend to learn this in your own time and to know for mild what you give, for moderate what you give, and for severe what you give. And also remember for MRSA, it should be vancomycin. This last one is infantile hemangioma. So some people call this a nevus, but it's not a true nevus. It's benign and it's red in color. So it's very common, 5% of babies would have it. And usually it might be a midwife or a doctor or even the parents who notice it while they're in hospital, just born. Usually it flattens out and fades by about 5 months of age, but it can grow until they're 18 months. Some are most are a lot smaller than the images on here, but they don't need treatment. All right, that brings us to genetic conditions. So Down syndrome can be picked up on antenatal screening, which you would have learned in women's health, but also through karyotyping postnatally, just using a blood sample. So Down syndrome can have a constellation of things it's associated with, but it's important to remember that it can come with a degree of intellectual disability and Alzheimer's, which presents in almost all patients. Usually symptoms arise at around 50 years of age, but then by 60, 70, it becomes very, very common. in people with Down syndrome, and the mechanism of that is slightly unknown. People with Down syndrome can also have hearing impairment, so that's usually conductive, vision impairment, different types of congenital heart disease, which is something you should definitely remember, especially for a counselling station. It's important to know the different types of heart disease or heart conditions that they would have. Also a range of abdominal malformations, thyroid conditions, and then the features or the identifying features, facially, a flat facial profile, having a broad nasal bridge, or some people call it a flat nose, almond-shaped eyes, small ears, small mouth, and a tongue that protrudes. And something that's a lot easier to recognize is hypertonia. So that's a body characteristic, but there's a range of things and degrees, and it's obviously individualized to the child. This next one is neural tube defects. So there are a range of factors that could lead to a neural tube defect. So one has been found to be folate deficiency in pregnancy, and there's also some fetal causes like specific trisomies, genetic conditions, or amniotic band syndrome. So the first one is the most common and also sort of the less severe. So that's spina bifida occulta, and that's just a vertebral bone defect, no herniation of neural tissue or meninges. So it's just the bone. It usually is picked up maybe on a newborn exam, where you can notice on the back, usually in the lumbar or sacral region, a patch of fat or hair, or it's just a small skin dimple, because again, it's a bone defect. The next level is called a meningocele. So that's when the meninges herniate, but there's no neural tissue, so no part of the spinal cord will herniate. And again, depending on the level of where the hernia is, and also the extent of the damage, it can come with a range of neurological outcomes. The next level is myelomeningocele. So that's when the meninges and also some neural tissue, so some part of the spinal cord would herniate. And again, depending on the level that it herniates and also the extent of the hernia, there can be different neurological symptoms. And this one is associated with Chiari-2 malformation. This next one I cannot pronounce, I'm really sorry, but this is one of the more severe or the most severe version, where portions of the neural tube actually just don't fuse at all. So you've got an exposed neural tube, neural tissue, that has no meninges, then no bone, no skin, nothing. The management for neural tube defects is mainly, obviously, folate supplements are, I guess, preventative. But if there's any screening in pregnancy, a high AFP would indicate a neural tube defect. And depending on the level of the defect, it's case by case, but there can be surgical management, but really large lesions might not be viable. Okay, fetal alcohol spectrum disorder. Unlike caffeine or some other substances, there's no safe amount of alcohol that you could have in pregnancy because of the risk of this disorder. So really, you should be able to identify some facial features and associated features of the condition. So it's the smooth philtrum with thin upper lips, a flat nasal bridge, upturned nose, and epicanthic folds. And it's associated with a range of sort of intellectual or growth deficiencies like poor executive functioning, behavioral issues, and growth deficiency during the pregnancy. Kids born with fetal alcohol spectrum disorder would usually have a smaller head and a slightly abnormal brain structure if it's imaged. And they have a range of cardiac and also eye issues like strabismus, refractive error. These next few genetic conditions are R3, so you should just be able to identify them on an exam from a description, but I'll give you a little bit more information that you might actually need. So Turner syndrome is 45 chromosomes XO, so there's a missing or partial X chromosome, and therefore it affects biological females only. On exam, it might be described as a patient being female, having short stature with a webbed neck, which is usually the most buzzwordy part, wide spaced nipples, and associated with delayed puberty and an aortic coarctation. Blood tests would show an increased FSH and little to no estrogen. Some features you might notice as a doctor or on exam: lymphedema in a neonate, recurrent ear infections, and also ovarian dysgenesis. So that's associated with the delayed puberty. And some exam questions or some actual patients in real life might present sort of around the age where you might expect the onset of puberty. And then you could find this as a diagnosis. Fragile X syndrome, on the other hand, is an X-linked dominant trait or condition, and it's on the FMR1 gene on the X chromosome. So it affects males much more than females. And usually on exam questions, it's been a male with learning difficulties, macrocephalic, with loose joints and flat feet. Kids with or people with Fragile X syndrome might experience learning difficulties, have intellectual disabilities, or some form of ADHD and ASD. Again, a reg once told me, Fragile X syndrome, everything is bigger. So you have a longer face, large ears, a larger head, and also larger testes. And also Fragile X syndrome is associated with seizures. Next one, compared to Fragile X, with Prader-Willi, everything is much smaller. So it's just a new mutation. So the methylation, the turn off genes, there's a deletion of one of the genes. And it can result in neonatal hypertonia and an insatiable hunger. So usually it's a hypothalamus issue. It's like a hormonal issue. So infants overeat and they can end up with infantile obesity. Some other features are almond eyes, being small in stature, small feet, small hands, and a narrow forehead, as well as hypogonadism. So that's why I remember Prader-Willi, everything's a lot smaller, because there's a range of things that come a lot smaller. Also, people with Prader-Willi syndrome have a degree of intellectual disability and might also have OSA. These ones aren't technically on the matrix, so do with that what you will, but they come up a little bit in past exam questions, and also it's just important to know in future for your future patients. So I've kept it in. So plagiocephaly, plagio means flat. So this usually happens to babies who have been in the NICU for a long time, especially if people working there, like nurses, doctors, aren't able to constantly rotate or move the position of where they're laying. And that can lead to a misshapen, sort of flatter head shape, as I said, due to extended lying. So the management is quite simple. You just change their sleeping position, give them more tummy time, or if it's quite a severe misshapen head, helmet therapy can also help shape it back into place. On the other hand, hydrocephalus is much more severe. So it's defined as the abnormal enlargement of the ventricles due to either having too much CSF being produced or an impaired clearance of that CSF. So this can come from lots of different things, but it can be present from birth. So that's congenital hydrocephalus, and that's associated with spina bifida. Whereas some acquired causes of hydrocephalus can be tumors, infection, or bleeding, which affects the clearance of CSF. So just having all that CSF in the ventricles eventually leads to an enlarged skull size in the infants, and it really often needs a surgical intervention. So that's a VP shunt, or if the cause can be identified, addressing that as well. I don't love buzzwordy medicine because I feel like it's actually quite important to know the conditions themselves. But this was just a list of a lot of buzzwords for specific conditions that aren't necessarily on the matrix, but that are tested. Or have been tested in the past. So up to you what you do with that. I've included them. But I'll move on to infectious diseases. So I'll do the big three, and I'll mention all the other ones on the matrix, but a lot of them are also covered in the GP matrix. In the women's health matrix, I would highly, highly, highly recommend looking and learning at all the torch conditions, because they're very important and they're also tested quite a lot, I would say. Immunisations, please learn the immunisation schedule in your own time. I don't really have any fun tricks or sort of memory aids. I'm really sorry. Yeah, unfortunately, my only advice is to just sit down and learn what vaccines are given at what age, and you can remember it by how many shots. Also learn the alternative schedule for Aboriginal and Torres Strait Islander children. This next one is meningitis. So it's obviously inflammation of the meninges. And it's very similar to meningitis you would have learned on the third year matrix, but it's important to know the bacterial causes because it can differ slightly in pediatrics. So for newborns or neonates, young infants from 0 to 2 months old, a lot of the causes of meningitis are group B strep, E. coli, and listeria. And then once they're 2 months or older, it goes back to being the classic or the more common causative organisms. On history, especially for a neonate, or it can be quite difficult to figure out if it's meningitis, but some signs, symptoms might be irritability, photophobia, and having a slightly altered conscious state. On examination is usually where meningitis can be picked up more easily. So that's having a full fontanelle, a high-pitched cry, neck stiffness, focal neurological signs, and then the Kernie-Brudzinski signs. And then if it's meningococcal sepsis, that purpuric rash. One tip, I don't know if anyone else finds this, but I learn the names of the signs, especially if they're very specific to a condition, but I don't actually know exactly how every sign is done. And on exams, sometimes instead of just giving the sign, they'll describe what the test is. So I know it's extra work, but I'd recommend learning what the signs actually are and how to perform them, because again, they are useful, and also it could help you out in the exams. So investigations for meningitis, the gold standard is a lumbar puncture, then urgent CSF microscopy and biochemistry. You can do bloods, especially blood cultures, or any coagulation studies if you have a good indication for it. And then neuroimaging is not usually recommended, or it's not routine for straight meningitis. But if you suspect encephalitis, if there's any focal neurological signs, which again might be difficult to find in very young kids, or if there are any signs of raised ICP, or if you're just really not sure, you can do a CT or MRI, but again, it's not really routine. Management for meningitis, I won't go through exactly what organism needs what antibiotic, but the most important management principle to remember is that once you decide to treat for meningitis, you can't delay antibiotics for more than 30 minutes. So if you decide it's meningitis or you decide to treat it, you have to give antibiotics. So learn what you need to give. You can give steroids if they're older than 2 months. So it's IV dexamethasone. So either give it just before you give antibiotics or at the same time as the first dose of antibiotics. Also think about, because they'd be acutely unwell, what fluid management and resuscitation you need to give. If they have any signs of raised ICP, edema, dehydration, or their serum sodium, you might need to figure out what the exact fluid requirement is, because it might not be just your standard calculation. Because they're so unwell, make sure you're regularly monitoring them. So their weight, head circumference if they're really young, and then the standard things you do in hospital, vitals, blood glucose, and then also you can do UECs. Depending on the causative organism, it can also be a notifiable illness. And then for any contacts, you need to start prophylaxis. All right, neonatal sepsis. So the most important takeaway for neonatal sepsis is figuring out if it's early or late. So in, I guess, on your PEDS placements, I remember I saw there was a risk calculator that most babies, when they're born, the pediatrician would do it. So that would calculate their risk of having sepsis. So for early onset, which is earlier than 48 hours after birth, so within the first 2 days of being alive, Some of the factors that could lead to early sepsis is PROM of greater than 18 hours, a maternal fever, because that could indicate any choreo, so another form of infection. If the mother was GBS positive during this pregnancy, or even if they have had GBS in a previous birth, or if their infant from a previous birth had GBS rather, or if the mum has any history of multiple obstetric procedures, which could increase a risk of infection. Fetal factors include fetal distress or being preterm, so less than 37 weeks, just because of a risk of being unwell, sort of indicates that. Early onset, again, is usually caused by GBS, E. coli, or Listeria. If they're preterm, so again, less than 37 weeks, it might be Enterococcus. All right, so that's early. Late onset is greater than 48 hours of life, and that can be caused usually by hospital stays. So a prolonged NICU stay, having any foreign bodies like IVs, cross-infection with staff who are seeing multiple patients, multiple babies, parents, or then any sort of malformations like of the urinary tract that could increase their risk of infection. And usually late sepsis is caused by things like coagulase negative staph, which is quite common in NICUs, Pseudomonas, Klebsiella, Staph aureus, and Candida, especially if they have a low birth weight. So investigations is obviously the priority is a septic screen, so blood culture and a VBG with lactate and glucose. Management is getting senior involvement early, going through doctors ABCD, and then getting IV access so you can start with empirical antibiotic treatment. So I won't go through every stage of treatment, but it's all there. And I'd recommend looking at the RCH guidelines, especially for this one. Next up is Kawasaki's. So that's febrile vasculitis of childhood. And currently the origin of this is unknown, but something that's always or very often tested, I think we found, is warm cream. So the diagnostic criteria of warm refers to a fever above 38.9 degrees for 5 or more days. And then cream refers to 4 out of 5 at least of conjunctivitis, a rash, extremity changes, adenopathy, and then mouth changes. So that's like pharyngitis or a strawberry tongue, which you can see labeled as B on there. So I won't go through all the specifics, but just remember that. It's quite a specific diagnostic criteria. The management for Kawasaki's is IVIG at a really high dose and then also aspirin. And this is because Kawasaki's has a high risk of coronary artery complications like aneurysms or dilatations. And these address that really. And something that's a bit buzzwordy again, high dose aspirin can precipitate Ray's syndrome. Infectious mononucleosis is EBV or the kissing virus, and it's more common in older teenagers or young adults and transmitted by kissing or sharing drinks. The clinical features, it's actually quite debilitating. So if someone's really unwell for a long time, you might think about EBV. There's an incubation period of 6 weeks. Usually it's asymptomatic in young children, but someone who presents with symptoms might have fever, feeling really unwell, fatigued. It comes with splenomegaly sometimes, pharyngitis, tonsillitis, and then bilateral enlarged lymph nodes. And then it can also have abdominal pain and a range of other features. The investigation is a monospot test. That's gold standard. You can also check for lymphocytes on a blood film or do white cell count, which is, I guess, routine anyway, a white cell count, but looking for that. And then management is just supportive, really. It's usually self-limiting up to 2 months. But because of that splenomegaly, there's you have to advise them not to do any sport just because of their risk of actually rupturing their spleen. And an important note for management is do not give amoxicillin because this can be confused with a bacterial infection. But if you give amoxicillin to someone with EBV, it causes a maculopapular rash. All right, viral hepatitis. I won't go through this in a lot of detail because I'm sure you all know hepatitis, probably better than I do. But an important note for pediatrics and hepatitis is that if you get Hep B when you're a kid, the younger you are when you get it, the more likely you'll end up with a chronic hepatitis or chronic liver disease. Dengue is R3, but in my notes, I found this really nice table. I have no idea who I've stolen it from. I think it might be a textbook or somewhere. But I found this really useful last year during exams because it summarizes what you need to know for these conditions for pediatrics, especially. So again, like I said, for hepatitis, Hep B in pregnancy, there is a vertical transmission risk, but there's a really high risk if you get it when you're young, especially as a neonate, that it ends up being chronic. And for Hep C, unfortunately, there's sort of no management for neonates really. But for dengue, it's pretty much the same as in adults. So I think you cover that in GP. And I'm sure you know it from the year before as well. All right, that brings me to the end of the presentation. I hope that was thorough enough. I didn't want to go too in depth in all the R3s, but feel free to ask any questions if you have any. And good luck for your exams. I'm sure you'll all be great.